My name is Christina Carter, and my team investigated the association between unemployment and its effects on heart disease. According to the CDC, about 1 in 4 deaths in the U.S. are caused by some form of heart disease. Coronary artery disease is among the most common form and is the cause of 370,000 mortalities in the U.S. annually. Coronary artery disease weakens the heart muscles and increases the risk of arrhythmias, irregular heartbeat, and heart failure. Plaque buildup in the arteries is a primary characteristic of CAD and is the initial cause of acute myocardial infarction, also known as heart attack. Healthy People 2020 set objectives to reduce the leading modifiable risk factors for heart disease, which included diabetes, high blood pressure, high cholesterol, cigarette smoking, unhealthy diet, physical inactivity, overweight, and obesity. However, as unemployment and job instability become a major source of stress for adults in America, new research started to observe unemployment as a potential risk factor for heart disease. The Archives of Internal Medicine investigated the cumulative effect of unemployment on risk for acute myocardial infarction. Their findings revealed that those experiencing low socioeconomic status, no health care coverage, poor behavioral patterns such as cigarette smoking and alcohol consumption, and high levels of morbidity in addition to being unemployed or retired had significantly higher levels of myocardial infarction than those not suffering unique hardships. The study demonstrated even after adjustments from confounding factors such as socio-demographics, race, ethnicity, and gender, that one's lifetime employment does in fact have an effect in cardiovascular events. Our team sought to further this research by investigating employment characteristics and history of heart disease. Since there are several forms of heart disease, we chose to tackle the most common one, which was coronary artery disease, as mentioned in a previous slide. Our research question was designed to compare employment characteristics among those considered working age and to determine whether each had an equal risk of CAD diagnosis. Through our initial research, most studies observed an association between unemployment and heart disease. So we hypothesized that there would be an unequal rate of CAD among the unemployed and those not in the labor force than those with jobs. Our second theory suggested that CAD rates fluctuated among the different employment characteristics. For example, whether a retiree versus a person between jobs had greater risk of CAD. We filtered our sample population to include only those considered working age, ranging from 15 to 64 as defined by the Organization of Economic Cooperation and Development. We then used the 2015 IPUMS dataset to retrieve test subject data. We used the Employment Status Code as our independent variable to verify different employment classifications. The dependent variable, coronary heart disease code, asked the test subjects whether they had ever been told they had CAD. We then controlled for smoking status, since it is a known risk factor for cardiovascular events. In addition to smoking status, we also controlled for age, since morbidity increases as we get older, and for those with or without healthcare coverage. Lastly, bivariate and inferential statistics were used to examine all the different variables for the purpose of determining if there was indeed an association. Because all the test subjects were categorical variables, the chi-square test was used to measure if there was statistical significance in our findings. First, I will review the findings for our control variable of health insurance coverage. The top chart demonstrates those without health insurance, and the lower shows those with health insurance. The legend on the bottom differentiates yes, they have been told they have CAD, and no, they have not been told they have CAD. Each chart will read the same way. The history of CAD was seen more in those with health insurance than those without. Lack of insurance can be seen as a barrier to care, causing a misinterpretation of true CAD incidents, since those without health insurance will not get health checkups. However, there is still a trend where there are more cases of CAD among those employed and not in the labor force. The chi-square statistic for those with health insurance is 4.811, and the p-value is 0.090221. The chi-square statistic for those without health insurance is 6.4212, and the p-value is 0.040332. The results indicate that there is a 0.09 chance versus a 0.04 chance that persons with health insurance has a higher rate of CAD. The control variable for smoke status revealed persons labeled as a sometime smoker, in addition to being unemployed or not in the labor force, had greater rates of CAD. Those not in the labor force had a significantly greater rate of CAD than both those with or without jobs, which continues the trend seen in the health insurance results. The chi-square statistic is 3.931 and the p-value is 0.140083. Since the p-value is less than 0.5, there is a statistically significant difference among those who smoke some of the time than persons who never smoked. According to the CDC, heart disease becomes more of a concern as we age. Starting with the age group 45 through 64, it ranked as the second leading cause of death in the U.S. For those reasons, I chose to explain the outcome of that particular age range. The control variable for age describes all valid cases for the age group ranging from 45 to 64. This time, unemployed persons and those working for pay have an equal rate of CAD. However, those not in the labor force had significantly higher rates of CAD. The chi-square statistic is 5.0526. The p-value is 0.079953. The p-value is again less than 0.5, showing that there is a statistically significant difference in the age group ranging from 45 to 64 and the rate of CAD. Results from our study demonstrates that one's employment status does in fact influence risk of cardiovascular events. However, we incidentally found that those with health insurance are likely to have higher rates of CAD since they have better access to health care. As rates of job instability increase, more Americans are living without health insurance, which can elevate health risk in general. This is why implementing universal health care is so imperative. Providing employment as medical intervention is not feasible, but providing affordable health care is. Universal health care coverage will eliminate several disparities among access to health care in terms of eligibility and affordability. If we can break down barriers and level the playing field, we can slowly improve health for all.